Welcome to the deep dive. Today we're jumping into something every healthcare system sees, well, constantly. Pediatric minor trauma.
It's a real paradox, isn't it?
It is. A fall, a cut. It's a rite of passage for kids. And yet, children with these quote-unquote minor injuries are just a huge continuous user of emergency services.
And that paradox is exactly where our source material starts. We're pulling from the handbook, Emergency Care of Minor Trauma in Children. The whole idea really is that we need to stop thinking of these injuries as truly minor.
I want to push back on that a little. If a scrape is, medically not a big deal, why do we need a whole deep dive on it?
Because the impact on the family, on the system, is anything but minor. Think about it. An ED visit means a parent has to take time off work, the child misses school, there are follow-up appointments.
And a lot of stress for everyone.
A huge amount of stress. So what seems small clinically can cause major resource drain. And, maybe most importantly, if we get it wrong, if we mismanage it or miss a safeguarding issue, the risk is incredibly high.
Okay, that frames it perfectly. So for our audience medical students, young professionals, our mission today is to give you a clear, systematic way to think about this. A kind of mental shortcut for these very common but very high-stakes situations.
And that framework, it has to start with the core philosophy of pediatric care. You have to create a child-friendly environment.
And that's more than just painting cartoons on the wall.
So much more. It's about separate waiting areas, it's about having child-sized equipment, and, just approaching the child with respect and compassion. A huge clinical pearl here is that you can often do a better exam through play or distraction, maybe with the child on a parent's lap, than on some formal, sterile examination couch.
That makes complete sense. You manage the fear, and the physical assessment gets a lot easier. So let's start big picture. Injury prevention and safeguarding.
Yeah.
What's our role as clinicians before the injury even happens?
We have to be educators. Every single time you see a family, it's a chance to give some simple, practical advice that might prevent that next visit.
Like what? What are we talking about in practice?
We're talking about really simple things. Gently asking about stair gates, making sure they know to store cleaning products and medicines up high in locked cupboards, and just, constantly talking about bicycle helmets. These are small things, but they work.
And the kind of advice we give, it has to change as the child gets older, right? The data shows the risks shift dramatically.
Absolutely. The source material lays this out really well. For the youngest kids, say under 3, almost all injuries happen at home or in the garden.
Because parents just underestimate how fast they can suddenly climb or move.
Exactly. They underestimate their mobility, so you see falls from furniture, burns from grabbing kettle cords. But then for older school-age kids, the whole scene changes.
Now it's the school, the playground, the sports field.
Right. And by the time they're adolescents, it's even further away. It's sometimes in high-risk places like, derelict buildings or near railway lines. It reflects a different kind of risk-taking. Just knowing the typical location for an age group tells you so much about the context.
That's a really powerful way to think about it. Okay, let's go to the most sensitive part of this. Non-accidental injury, or NAI, and neglect.
This is an absolute cornerstone. We have a professional duty or responsibility to identify when a child might be getting suboptimal care or is being abused. It's a small percentage of cases, but missing it is, it's catastrophic.
And NAI isn't always about obvious physical abuse. It can be more subtle.
Much more subtle. It could be neglect, like a parent waiting days to bring in a child with a serious injury, or it could be repeated injuries where the story just doesn't quite add up.
The source material is really emphatic on this. We have to keep a high index of suspicion. What are we looking for beyond, say, a pattern of bruising?
It's often about the inconsistencies. Does the story from one caregiver match the story from the other? Does the mechanism they describe actually fit the injury we're seeing? A simple-sounding fall that results in a really complex fracture. That is a massive red flag.
So our job is twofold. Treat the injury, but also document everything objectively.
Meticulously. That documentation is paramount.
Okay, let's transition to the immediate clinical response, which really all comes down to comfort.
Sure.
So section 2, pain management. Why is pain so often undertreated in kids?
Well, it's a mix of things. It's genuinely hard to assess. It's tough to separate out true pain from fear or anxiety. And another key thing is that a child in a lot of pain might not be screaming. They
Mhm.
might be quiet, withdrawn, even lethargic.
Right, and staff might see that quietness and think the pain isn't that bad.
Precisely. And then you have another layer, especially with slightly older kids, where they might actually deny being in pain.
Because they're afraid of what comes next.
Exactly. They think, if I say it hurts, they're going to give me a needle, so they downplay it. We have to be smart enough to look past that denial.
And those linear 0 to 10 pain scales, they're often too abstract for a little kid. So how do we get a better, more objective handle on it?
We have to use composite scores. The UK's Royal College of Emergency Medicine really pushes for this. You combine subjective things like the FACES scale, which is okay, but it's flawed on its own, with objective things. Is the child guarding the limb? What's the injury? A compound fracture is objectively painful, period, even if the child is silent from shock. And you have to reassess, always. Check back in 15 or 30 minutes after you give something to see if it worked.
Before we even get to the drugs, what about the simple stuff, the psychological and practical strategies?
Psychological preparation is probably the best painkiller we have. The staff need to be confident, sympathetic, and honest. You never lie and say something won't hurt, but you can frame it positively. And then distraction is. It's just king.
Age-appropriate distraction.
Right. Murals on the wall, music, a simple game, or just letting them watch something on a parent's smartphone. And practically simple things. Elevation, a good splint, and a cold pack, just making sure to wrap it so it's not directly on the skin.
Okay, let's get to the high-yield info for our learners, the pharmacological ladder. Let's start with mild pain, so scores 1 to 3.
This is your standard first-line stuff, always weight-based. We're talking oral paracetamol at 15 milligrams per kilogram every 4 to 6 hours, or ibuprofen at 10 milligrams per kilogram every 6 to 8 hours.
Simple enough. What about for moderate pain, scores 4 to 6?
So now we step it up. We combine agents to hit different pathways. You can continue the paracetamol and add a stronger NSAID, something like diclofenac. An oral opiate is an option, but you have to know the local rules. In the UK, for example, codeine is a no-go for kids under 12.
And severe pain, 7 to 10. This is where we need something that works fast, but ideally without causing more trauma by, sticking a needle in a terrified child.
This is where intranasal opiates have been a complete game changer. They should be your priority.
What are we using?
Intranasal diamorphine at 0.1 milligrams per kilogram or fentanyl at 1.7 micrograms per kilogram. The benefit is just huge. It works fast, within a couple of minutes, and you get a good 30 to 60 minutes of pain relief and anxiety reduction. That gives you a calm window to then get an IV in if you need one.
That's a fantastic clinical workflow. What about topical anesthesia, like for sewing up a cut? I know there's a big safety warning with LAT gel.
There is. LAT gel, that's lignocaine, adrenaline, tetracaine, is great for numbing a wound. But the lignocaine in it gets absorbed into the bloodstream. So if you use it, you have to be incredibly careful with any subsequent injectable anesthetic. The total dose of lignocaine you can give is tiny, about 0.1 milligrams per kilogram, to avoid systemic toxicity.
Which can cause seizures.
Seizures, arrhythmias, it's serious.
Yeah.
And a quick word on procedural sedation for setting a fracture or something.
Right.
This should only, and I mean only, be done in a center with full resuscitation gear and trained staff. Ketamine is often the go-to. It gives you this safe dissociative state, but you have to watch for the side effects like hypersalivation or some agitation as they're waking up.
Okay, let's move on. Section 3.
Yeah.
Wound care and foreign bodies. When a kid comes in with a cut, you're saying the history is almost more important than the wound itself. Why?
Because the mechanism tells you what might be hiding underneath. Was it a clean slice or a crush? Did it involve a bite, which is full of bacteria? You have to actively rule out damage to tendons or nerves, and you have to think about hidden foreign bodies, especially glass.
And it feeds back into that NAI screening, making sure the story fits.
Always.
So kids heal fast. What determines how good the scar will look?
Well, two main things. Healing is fastest on the face and scalp because the blood supply is so rich, and slowest on the legs. But the quality of the scar, that really depends on Langer's lines.
The skin's natural tension lines.
Exactly. If a cut runs parallel to those lines, there's less tension, and it heals with a much finer, less noticeable scar.
And which wounds should have us on high alert for infection?
Puncture wounds. They are incredibly high risk. The object goes in, the skin closes right up over it, and you've created this perfect little sealed, airless pocket deep inside. It's an ideal environment for nasty bacteria like tetanus.
And wounds with dirt or soil in them.
Yes, anything with organic material. That carries a huge bacterial load and needs a really, really thorough cleaning.
When it comes to closing a wound, is it always sutures?
Not at all. If there's not much tension on the wound, adhesive strips or skin glue can give a cosmetic result that's just as good, sometimes even better. But the big rule is about timing.
Right.
If a wound is more than 12 hours old or 24 hours on the face, you generally should not close it. You leave it open to heal by itself. Closing it just traps bacteria inside and massively increases the infection risk.
And suture removal is faster in kids, too.
Yep, much faster. Usually day 4 for the face, day 5 for most other places.
Okay, foreign bodies. Let's talk glass. A common point of confusion. Can you see it on an X-ray?
The rule of thumb is yes, most glass is radio-opaque, so if you even suspect there might be glass in a wound, you have to get a soft tissue X-ray. And this is the bit people forget. You have to get another X-ray after you think you've taken it all out, just to be sure.
Now for the highest stakes foreign body of all, the button battery.
This is a true life-threatening emergency, especially the bigger ones, 20, 25 millimeters. If one of those gets stuck in the esophagus, it's not a chemical leak we worry about. It's electrical.
It creates a current.
It creates a current in the moist tissue and causes liquefaction necrosis. It literally dissolves the tissue. This can happen in as little as 2 hours. It can perforate the esophagus or even erode into the aorta. It's catastrophic. This requires immediate senior surgical involvement. Urgent X-ray, urgent endoscopy, no delay.
Let's move to our final section on musculoskeletal trauma. What makes a kid's bone different from an adult's?
They're just less brittle. They have more collagen, which makes them more pliable, more bendy. And that's why you see these unique fracture types, like a green stick fracture where it breaks on one side but just bends on the other.
Like a green twig.
Exactly. Or a torus fracture, which is more of a buckle from a compression force. But the most critical difference is the physis, the growth plate. It's the weakest part of the bone, so it's really vulnerable to injury.
And to classify those growth plate injuries, we use the Salter-Harris system. The mnemonic is SALTR.
Right. SALTR, slip, above, lower, through, and ram. And by far the most common one you'll see is type 2. That's a fracture that goes through the growth plate and then extends above into the metaphysis.
So for most fractures, it's about immobilization and pain relief. When do we absolutely have to call an orthopedic surgeon right away?
Any fracture with significant displacement or angulation, any confirmed growth plate fracture, because that could affect how the bone grows later, and most urgently, any sign at all of neurovascular compromise, loss of pulse or sensation distal to the injury.
And let's circle back to NAI one last time. What are the specific fractures that should be immediate red flags for abuse?
The classic one, the one that's almost pathognomonic, is the corner metaphyseal fracture. It's this tiny little chip of bone that gets pulled off where the long bone meets the growth plate. It's caused by a violent shaking or twisting force.
Hard to spot on an X-ray.
Very hard to spot. Also, a spiral fracture of the humerus, the upper arm bone in an infant, and any femur fracture in a child who isn't walking yet. These injuries are very, very unlikely to be accidental.
Let's end with the limping child. It sounds simple, but it can hide some really serious problems that aren't trauma at all. What are the two big diagnoses we can't afford to miss?
First is slipped upper femoral epiphysis, or a SUHI. The top of the femur, the ball of the ball and socket joint, slips off. And the tricky part is, it often doesn't present with hip pain. It presents as referred pain in the thigh or even the knee.
So you have to look for it on the X-ray.
You have to look for it. Check Klein's line. And if you suspect it, that child needs an immediate orthopedic referral and must not bear any weight.
And the second one?
Septic arthritis, a bacterial infection in the joint. This is an emergency because the infection can destroy the joint cartilage in a matter of hours, leading to, permanent disability. It needs immediate referral and drainage.
That's a huge amount of really vital information. I think the main takeaway for you listening is that managing pediatric minor trauma, comes down to a few core things. Prioritize the child's comfort, use your analgesia smartly, and always, always keep that high vigilance for safeguarding issues.
And, if you step back, the skills you learn here are universal. Things like psychological prep, distraction, confident communication. These are things you can use to manage anxious patients in any field of medicine, from geriatrics to dentistry. It all starts with respecting the patient's distress.
It really does. Okay, time for our final review exercise to lock this in. Here's the scenario. A 2-year-old comes in after a fall. The child is limping, but is otherwise pretty calm. The X-ray of the lower leg is read as normal, but the mechanism involved a twisting motion. What common pediatric fracture is highly suspected, what's the right way to manage it, and when should you do a follow-up x-ray.
So what you're highly suspecting here is a toddler's fracture. It's a non-displaced spiral fracture of the tibia. For management, you need to be aggressive. You immobilize in an above-knee cast, even with that negative initial x-ray. Then you bring them back for a review x-ray in about 10 days. You might not see the fracture line even then, but you will see callus formation, the sign of healing, and that confirms the diagnosis and tells you to continue the treatment.